So we're going to start off with the debate, and Oscar Traynor is going to be moderating the debate. So I'd like to ask Oscar to come up, and we're going to start off with the vote on the debate. But I think Oscar wants to say a few words first.
Good morning, ladies and gentlemen, and welcome to this first session of the 2014 Icoset meeting here in Harrogate. My name is Oscar Traynor, and this first session is a debate. And the title of the debate is Supernumerary Training is Better Than the Traditional Apprenticeship Model. Speaking on the debate, we have two of the great giants in surgical education in the world today. Dr. Richard Resnick, originally from Montreal and went to medical school in McGill in Montreal. He did his general surgical training in Toronto and then went to do a fellowship program in colorectal surgery in the University of Texas in Houston. Along the way, he did something which was rather unusual at that time. He did a master's in medical education at SIU, Southern Illinois University. He was appointed to the staff of the University of Toronto in 1987, where he pursued his interests in colorectal surgery, but very rapidly developed an international reputation for his interests in surgical education. And his name has become synonymous with OSATs, the Objective Structured Assessment of Technical Skills. He became the inaugural director of the University of Toronto Centre for Research in Education, otherwise known as the Wilson Centre. And in 1999, he was appointed Vice President of Education at the University Health Network in Toronto. In 2010, he moved from Toronto to Kingston, Ontario, where he became Dean of the Faculty of Health Sciences at Queen's Medical Centre in Kingston, and also CEO of the Southeastern Ontario Academic Medical Organisation. He is well known around the world for his contribution to surgical education, and I think it would probably be fair to say that he is the best known person in the field of surgical education in the world at the present time. Professor Angus Wallace was originally from Dundee in Scotland and went to medical school in St Andrews Medical School. He is Professor of Orthopaedic and Accident Surgery at Queen's Medical Centre and Nottingham City Hospital. His clinical interests relate mainly to surgery of the shoulder and elbow, and he's acknowledged to be one of the most experienced shoulder surgeons in the United Kingdom. He also has interests in sports and exercise medicine, and he's chair of the National Sports Medicine Institute. He has, on regular occasions, been in the public limelight, firstly in 1989 when he played a major part in the Kegworth air disaster, and he treated many of the victims of that disaster. And following this, he made some fundamental recommendations for changes in the brace position for emergency landing, which have since been implemented by airlines around the world. More famously, a number of years later, he performed a life-saving surgical procedure on a fellow passenger at 36,000 feet on a British Airways flight from Hong Kong to London when the passenger developed a tension pneumothorax. But it's his contributions to surgical education for which he's best known. He has held many important positions in surgical education. He's been chairman of the Intercollegiate Examinations Board in Trauma and Orthopaedic Surgery, chairman of the SAC in Trauma and Orthopaedic Surgery, and he has a major interest in health informatics. He was one of the 4 people who were involved in developing the e-logbook, which is now used by surgical trainees throughout the UK and Ireland. He is well known for his outspoken views on surgical training, and on his website he says that he is irritated by trainees who are not prepared to read up on surgical procedures before theatre, or surgical trainees who are not spending sufficient time in the surgical skills lab practicing their skills. So I think this promises to be a very robust debate, and we have 2 very outspoken speakers. We will allocate 10 to 12 minutes to each speaker initially to present their case. Dr. Richard Resnick will be speaking for the motion, and Professor Angus Wallace will be speaking against the motion. And following their initial presentations, we will give each man 5 minutes for rebuttals. And then at that stage, we will then open the debate to the floor for comments and questions. But before we start, we are going to take a vote from the audience, and we're going to repeat this vote at the end of the debate and see which speaker has managed to sway the audience to the greatest extent during the course of the debate. So the motion for the debate is supernumerary training is better than the traditional apprenticeship model of training. And you can either agree or disagree. Now, the technical people who are running the voting system for us. So you vote either for or against the motion, yes or no. Okay, so at the present time, 56% of the audience feel that supernumerary training is better than the old apprenticeship model, and 43% feel that it is not. So let the debate begin, and we will see how that fares out at the end of the debate. So our first speaker is Dr. Richard Resnick from Queen's Medical Centre in Kingston, Ontario. Richard.
Well, thank you, Oscar, and thank you for that kind introduction. I understand now that you also have a history at Queen's, so we have to be friends. We can't be bitter enemies. And you may have noticed my little trick here in that as I've changed the title a little bit to because that's what I thought we were debating, to competency-based education. But I think the principle is the same, and I'll expand on it in a few seconds. So here are the essential issues. Training is too long. We need to start our concept of training with what our society needs. We need to define those jobs, whether that be a generalist working in a rural environment or a subspecialist working in a large metropolitan urban environment. And then once we define the jobs, then we need to train as quickly and efficiently towards those jobs as possible. And we need to recognize that the trainee will deliver service, will always deliver some service, but that service is being done in the context of a training program, as opposed to somehow learning in the context of doing service. And that's my thesis. Right now, we're graduating folks who look like this because our training programs are so long. And we need to be mindful that the curve of decline probably starts just before your age 40 and falls off very rapidly. So graduating surgeons in their mid to late 30s is not a good thing. We need to work hard on changing the balance between service and education that tips it far aside in favor of the education side. And I would start with this slide here that was published in New England Journal about a decade ago that reminds us where we are in academic medical centers. These series of boxes relate to 1,000 persons in society, 800 of whom might report symptoms, 327 seek medical care, and as you can see, one person ends up in an academic medical center. So we can't be myopic about a training system that prepares for the entire society by virtue of just looking and focusing on that one hospitalized individual in one of our major teaching hospitals. In the UK, it is true that for the most part, hospitals across the UK do training and rely on trainees, but that's not necessarily axiomatic. Certainly in Ontario, a large province where I live in Canada, a vast majority of hospitals function very well, providing excellent care for patients without a reliance on trainees. This recent report was done in Canada, which speaks to the issue of work hours, which we have to include in the debate in terms of how we're functioning in 2014. And this was done a pan-Canadian consensus on the issue of work hours, and I've just extracted a few points from it. The first point it comes up with that residents are learners and care providers, and that duty hours are training hours and integral to patient care. Residents are vital providers in a health system, and duty hours, the report of 24 hours or more consecutive hours should be avoided. But they came up with some other findings which were interesting. First, that traditional duty hours, as we all know them or knew them, present risks to physical, mental, and occupational health, and that fatigue can affect performance. But it's not necessarily axiomatic that a tired doctor is necessarily an unsafe doctor, and nor was there conclusive data that work hour restrictions are necessary for patient safety or impact on academic performance. This is the most balanced view of the work hour debate that I've ever seen. 3 years ago in the UK, Temple, of course, did a major review and concluded that the work hour disruption can indeed be turned around to be a catalyst to reconfigure and redesign service and training, that traditional models waste learning opportunities, that consultant ways of working often support these traditional models, and that if implemented, it could have positive impacts. These are the issues that I took out of the Temple report that I believe he got right. We need to consider implementing a consultant-delivered service. Service delivery must explicitly support training. Every moment must count. Every moment can't count if it's myopically driven by filling out thousands of forms by young doctors in hospitals as service requirement. We need to recognize and develop and reward trainers, which is not systematically being done in the UK, and training excellence requires commitment to planning and monitoring. I'll talk about this a bit tomorrow in the Shape of Training report that Professor Greenaway has just written, but in short, I would absolutely not recommend this report, this scheme for surgical training, and I'll expand on that tomorrow as to why I believe that would be problematic for surgical disciplines. So we took it upon ourselves 4 years ago to start a new training model with some colleagues of mine. You'll be happy to know Angus in orthopedics. And of course, they're the most bright and brilliant people in the world, so they have to be right. As of this past year, we trained 27 residents in a competency-based system that was not time-based with the help of our college and our government. It's a modular curriculum. It produces surgeons and not just technicians, being respectful to all of our competencies expressed in CAMMED's roles. They finish when they finish, as opposed to X number of years doing service on a particular ward, and we evaluate them comprehensively. Their training looks very different from any other training that I know. They don't start on the wards, they start in a boot camp for 2 months to learn skills. They have their own secretary who sources out learning experiences for them. They're not assigned to Dr. Beard's service, nor to Dr. Pellegrini's. They're assigned to a module where they have a series of learning objectives that they have to satisfy. They never hold the sticks as a fourth assistant. They either serve in an operation as the actual operator or as a senior assistant, and we train them to benchmark. This table shows the amount of times that these residents are assessed. In the blue is the regular program, and the red is this new CBC competency-based curriculum. You can see it's six-fold the number of assessments that we're using. This is the key to a proper competency-based system. I've just shown one slide because I only have 10 minutes. In every dimension, in every way we could test them, they dramatically outperformed the residents who are on the regular training scheme, which is what I'm proposing we need to change. We only have 3 residents who've come through the first complete 4 years, because we started with 3 residents and then moved up from there. But you can see here, and this is after medical school, as opposed to in your system, after about 14 years rummaging around as an SHO, I'm teasing, after medical school, 38 months later, the first resident graduated, and Dr. Harris signed the paper so that he could write his examination. The second, after 40 months, and the third, in the traditional time, it's taken most of our residents 60 months after medical school. As I said, we started off with 3, then continued with 3 the second year. The third and fourth years, we took 5. But I show this slide for one reason. We've stopped doing the regular program. And 0 people entered the regular training program in Toronto this past year because the results were just so overwhelmingly positive in every dimension that we measured. And hence, all 11 entrants into the orthopedic program in Toronto are now in a competency-based system. So I'll end by saying we can't tweak the regular system, not with the pressures that we have. We have to think creatively, and we indeed are at a precipice. The 48 hours, or whether it's 80 hours in the US or 60 hours in Canada or 58 elsewhere, will not go away. New models, both of service and training, are essential. And we can no longer afford 16 years of post-secondary education to create a surgeon. It doesn't happen in any other profession. So we need to be a competency-based system, and that training needs to be an essential component, essential principle in the elaboration of a training program. So thank you, Mr. Chairman, for allowing me to express my views.
Thank you very much, Richard. We're going to move directly now to Professor Angus Wallace, who is going to speak against the motion. Angus.
My background is listed on the first slide. I've examined 22 times in the intercollegiate exam. I've chaired the Intercollegiate Exam Board, the SAC in Trauma and Orthopedics, and I've actually been on the SAC for 11 years. So I have lots of experience of seeing people come through training and seeing them at the end of training. An apprenticeship teaches you a lot more than just technical skills. And we know that from the program The Apprentice, where during that program you see people developing all sorts of skills. So I rather fancy myself in that position, appointing the apprentice and making the apprentice success. There is much more to being a surgeon than just doing surgery. O wad some power the gift they gie us, to see ourselves as others see us. It's really important that God give us the power to see ourselves the way our patients see us. And we have to have a number of skills in order to do that. We started off as barbers, and Thomas Vickery was the first leader of the Barber Surgeons Company. And he made some very valid points about surgeons and surgical requirements. They should be learned. They should be expert. They should be ingenious. And they should be well-mannered. And in fact, all of these still apply today. And when you look at what our trainees think about their training, we find some fantastic contributions. And this guy, Isaac Thangasamy, produced a prize-winning essay on the attributes of a good surgeon in Australia. Knows exactly what is expected from him. Patients come first, above reproach. Endeavour to instruct the student placed under him and impart to his student his wisdom. Now, the NHS has changed an awful lot over the last 30 years. I've worked as a consultant for 30 years. The first 10 years, it was a consultant-led delivery of NHS care. It was cost-effective, but there were care deficiencies because trainees were doing a lot of the operations. For the next 10 years, we were told we were going to have a consultant-based service where the consultant did most of the work. And it very clearly became obvious to the government and the Department of Health that they couldn't afford that. So the last 10 years has focused on a hospital team-based delivery of healthcare. It brought in, to reduce costs, and medical duties taken over by other staff, nurse practitioners, physio-specialist practitioners. I now work with a nurse practitioner alongside me, and I have a physiotherapist running an outpatient clinic which is following up my patients. So my practice has changed. I've thought about the attributes of a good surgeon. And I think these are all important. It's not just the technical skill, the ability to operate. It's the ability to communicate, your judgment, your empathy, your communication skills, organizational skills. And you pick these up if you are working as an apprentice. You don't pick them up by floating in and doing a few operations and walking off, which Richard is recommending. You actually want to work alongside and with somebody to see how they run their business. Now, what you ideally want is to be good in all these categories. So what I'd like to ask is, anybody in this room who believes they are good for all these categories, can they please put up their hand? Right. None of us are perfect. The other thing that we need to appreciate is that things are changing, and you have to learn how to cope with change. When I started as a consultant in shoulder surgery, it was all open surgery. In 1990, Tim Bunker and I wrote a book on shoulder arthroscopy when it was just coming in. And then nowadays, half my practice is keyhole surgery. So you have to learn to develop skills which are transferable during your lifetime. We do know that the old apprenticeship model was not perfect. There was patronage, trainees were used and abused without being trained, and trainers were not educated to deliver training. These are the bad things about the old system. However, we were very fortunate when a group of orthopedic surgeons and an occupational psychologist came together and developed OCAP, the Orthopedic Competency Assessment Program, which started in 2002, developed to 2009, was then migrated into ISCP, and actually is not working nearly as well now as it did before it migrated into ISCP. So we do need to address that. But I take my hat off to David Rowley and David Pitts, who led that team and who introduced the concepts of procedure-based assessments and trainer profiles. Trainer profiles were wonderful. In fact, one was alluded to by Oscar at the beginning, my trainer profile, where I say what my practice is, how I like my trainees to behave, etc. The other thing that has helped us and improved apprenticeship training is the electronic logbook, which has 24.5 million entries at the present time. But this has allowed the SACs, and I can speak particularly about orthopedics, to monitor the exposure that people are getting to both attending operations and doing operations. And this you can do as an apprentice, but be monitored from a distance. When you actually look for evidence-based papers in relation to training, I have to admit that Richard Resnick is the leader in the world, but I don't believe he's got it right. I think that by mollycoddling his trainees, protecting them from the pressures associated with working in a clinical setting, then he is not training them appropriately for the 21st century. We are all involved in dealing with this balance between surgical training and healthcare delivery, and trying to get one right compared with the other. The European Working Time Directive really reinforced some of the problems we had, because we suddenly found that the delivery of health care became really difficult when the 48 hours came in, and training became bad. We addressed it, and we're getting better. And the reports that Richard has alluded to, John Temple's report, The Shape of Training, David Greenaway's report, and the most recent report by Norman Williams on the implementation of the Working Time Directive, have all had influences on us. 4 reports in 4 years. Well, actually, they're all talking about a similar thing. And what happened was that the European Working Time Directive, when it came in, emphasized the fact that we had to deliver health care, and training got out of kilter, and we couldn't train well enough. John Temple's report emphasized that we got to train better, but the Department of Health could not cope with it, because there were too many recommendations in John Temple's report that actually removed staff from NHS work. And as a consequence, the emphasis on training resulted in a deterioration in being able to deliver health care, which is why David Greenaway was asked to provide another report to try and balance the system. And David Greenaway's report on the shape of training is much more about delivering health care than it is about training. It's very light on training, and it focuses mainly on delivering health care. So presumably, that's what he was asked to emphasize. And Norman Williams, with his report, is trying very hard to get the balance between delivering health care and delivering training right. Here are 2 sections from the shape of training. Appropriate organizations, including employers, must introduce longer placements for doctors. I agree with that. 4 months is not long enough. 6 months is minimum. 12 months as an apprentice working with somebody is good, but it shouldn't be one person, it should be a group of people. What disturbed me in David Greenaway's report was appropriate organizations should review barriers faced by doctors outside of training who want to enter a formal training program to access credentialed programs. What he's saying is non-trainees should be treated similarly to trainees, and that is a problem. The apprenticeship training we have at the moment is not perfect, and we need to change it if we're going to make it successful, which I believe it should be. We need to identify the best surgical trainers, and no consultant in the UK has a right to have a trainee, although many feel they do. Every trainer should have a trainer's profile. This has got lost since OCAP migrated into ISCP. I had a lovely OCAP profile saying what I did, what I trained in, how many operations I could deliver to the trainee, but that doesn't appear in ISCP at the present time in a satisfactory way. And you must ensure that appropriate trainer's time is created for training the trainee. And the job plan of the trainer should have training time allocation. And if there is no training time allocation, there should be no trainee allocation. And that's not rocket science, that's common sense. And the reason why I say they should have allocated trainer time is that it should be allocated PA time. And many of you will not have done this calculation, but you are paid £36 an hour as a new consultant on your PA allocation. But on your on-call allocation, you're paid £4 an hour if you're doing an arduous on-call, and £1 an hour if you're not. We've got to improve our UK apprenticeship surgical training, and we can do that by auditing the trainees who are currently working, looking at which part of their working week is giving the best training, restrict full shift on-call rotas, and explore ways of releasing trainees from clinical commitments of least value. And their training does need to be monitored. That is not rocket science. And we are very dependent on the trainees who are publishing helpful papers about how to get around the European Working Time Directive and how to improve our apprenticeship training. And modern training is very dependent, not just on learning in the operating theatre, but it must include addressing surgical skills using simulation. Claire Marks, President-elect of the English College, and myself published 2 papers in the National Health Executive. The first paper was on orthopaedic training, time for change, in 2009, and the second paper was on reconfiguring trauma care. The NHS service in the UK needs to be reconfigured to allow the trainees to be trained better as apprentices in the future than they have in the past. And I believe we can make the apprenticeship model work. I think it's the best model. I think that the trainees learn enormously from working alongside their consultant trainer. And I think dabbling in training by jumping in and out through different units is not the way forwards. Thank you very much. Oh, yeah, that's fine.
Thank you, Angus. We're going to give each speaker a short time to address the points raised in the other speaker's presentation. I would like to keep this very short because we're running a little behind on time, and I do want to give plenty of time to the audience to participate in this debate also. So, Richard, if we could keep it to maybe 2 or 3 minutes of reply.
I'll try to do that. Is the audiovisual technician here? I'm wondering if you could just pull up my slides. I just want to show one slide, if I could, if that's possible. Yes, there we go. I'm just going to show one slide, if I might, because I just want to show my learned colleague that he doesn't quite understand the program that we're trying to create and what we're trying to do. So this is a scheme of the new training scheme in the orthopedic program in Toronto. What's important is not to look at the words, but just look at the colors. So pink is where we teach and test the communication role. I can't see what color, the collaborator role. Blue is the manager role, the health advocate role, and yellow is the scholar role. So we are trying to teach all of the competencies that you suggest are so necessary, and we would agree, but they're taught in this curriculum, and not only are they taught, but they're also assessed. So individuals have periodic assessments on all of the competencies, and it's not just about teaching someone to be a technical surgeon. Indeed, it's quite the opposite. I'm not suggesting that either a consultant do all the work or that trainees do all the work, but that there be a system of graduated responsibility where consultants gently guide trainees as they take on more and more responsibility. And I certainly agree with the concept of deploying multidisciplinary teams. What concerns me about my opponent's thesis is that I think he's subject to what's been happening with surgical education in the last decade or two. And you nicely articulated the 4 reports that are most recent in the UK. I'm afraid they all suggest that what we do is we tweak around the edges and not cut to the heart of the problem. The heart of the problem is we don't have a sensible approach to comprehensive training within our training system and are trying to accommodate all of the exigencies, be they work time directives or consultant expectancies in the context of our training. And that's why that system won't work anymore, and we need new models of training. So thank you very much.
Okay, and now Angus Wallace has a few moments to reply.
Richard has produced in Toronto a good training system. It is bankrupting his healthcare system because it is really expensive. How many $1 million have you got, Richard, for developing this system? Please tell me. It's a few million.
We've got a grant of $1.5 million.
$1.5 million. So we have to ask ourselves, could our healthcare system afford that sort of payment for trainees? Now, our trainees are actually paid very well at the moment. And they're paid by, if you like, the educational side of medicine. They're not paid by the hospitals, which is fascinating. And during the last 30 years, there has been a debate about whether trainees should be paid 50% by the hospital and 50% by the training bodies. And at the moment, that is not the case. But I still believe, Richard, that a trainee coming through with a consultant, working with them regularly, learns more than just the technical side of the operation. They learn the ability to manage really difficult situations. When an operation goes wrong, how to manage the patient. And I'm not convinced that your system, the way you've developed it, necessarily allows the trainee to develop these skills. How to cope when a standard operation goes wrong. How do they address, and it's a problem that we've had in this country also, because we have 4 levels of knowledge in relation to surgery. One is knowing about, one is your ability to do a standard operation, and one is the ability to do a standard operation and the complications. Now, it's the and the complications that I would worry about in your training program with a limited number of operations being carried out by the trainee. However, your system is attractive, and I look at our system, and you have accused us of only adjusting our system a little bit, of trying to turn the knobs a little bit to make it work better. And actually, you are absolutely right. Our system needs a radical change. But it needs a change in order to make apprenticeship more successful, and apprenticeship in the old-fashioned way rather than in your new way. I enjoyed listening to you. I respect what you've done. I just don't agree with it. Thank you.
Okay, We're now going to open the debate to the floor for any comments or questions. If you have questions, there are microphones on both sides of the hall. If you go to the microphones and introduce yourself, and we'll take the questions. I am conscious that we are extremely fortunate to have in the room today a number of very prestigious international surgeons, including Carlos Pellegrini, President of the American College of Surgeons, Vasilios Papalois, President of the Surgical Section of UEMS, Ken Harris from the Canadian College, John Collins, previously Director of Education in the Royal Australasian College and author of the Collins Report on the foundation years of surgical training in this country. So we have a lot of prestigious international surgeons, and hopefully they will all contribute to the debate. Vasilios, I think you're first there.
Thank you very much, Oscar. We had some fantastic arguments from two giants in the field, but both of them being so great, they had the humility to accept what they are proposing is not perfect. So what is wrong in combining the two? Having competency-based training coupled with proper apprenticeship and even more mentorship, proper professional mentorship, which is what our trainees are asking for.
I agree with you, and I think that at long last the GMC has come round to the agreeing the concept of recognized trainers who have proper training in how to deliver training to their trainees. Interestingly, we have some fantastic trainer surgeons, and I've been involved with consultant appointment committees in 6 hospitals during the last year. Fascinating to see people at the end of training moving into a consultant job, and what they have learned and what you get from them at their interview. And what you get from them are beautiful descriptions of why trainer B was so good and what he taught them. And I found that extremely valuable.
Well, thank you for your comment. I'd certainly agree that we shouldn't undervalue the role of mentorships and the role of our trainers in mentoring our students. Where I think it's flawed and problematic to go back to the old apprenticeship system where someone might be exposed to 1 or 2 trainers for, let's say, a period of a year and just happen to become an expert at what happens to come in that person's service, is that in totality that doesn't represent a comprehensive curriculum, certainly not an efficient comprehensive curriculum if someone's going to be exposed to one sector, one type of training for extended periods of time. So to a certain extent, we are talking about a blend of the two, but I think more importantly, I'm talking about dismantling the concept that someone goes and spends a year with a particular individual and just happens to learn what comes through the door of that particular individual.
Okay. Any other questions? How should we train trainers? How should we sign off our trainers in terms of their own competency to train their surgeons?
We've not done it very well up till now. We have some very good trainers who have become involved with improving their training locally in their unit, but across the UK, I think we are quite deficient in trainers, and I think there is a need for us to address that. I suspect in Ontario, you've actually got a better grip of helping trainers to train than we have in the UK, and I recognize our deficiency in the UK.
Well, I don't think you have to look too far. Craig McElhaney, I think, is in the room and has started a wonderful program in the Royal College of Surgeons of Edinburgh, Faculty Trainer Association. I forget the exact title, but where the principles, I think, are appropriate. First, they have to be recognized. There has to be a robust program of teaching the trainers. And thirdly, they have to be paid for training, and there have to be deliverables on both sides. There has to be an explicit payment for the training, and then there has to be explicit training for the payment. You need to develop systems that have that bilaterality.
Dr. Pellegrini.
I heard you give the talk, Richard, today, and I was so enthusiastic until I heard Angus. And then one of the questions that came to my mind is, I remember that you described this competency-based training in 2005 or so. I remember reading it in sometime around that time, because I put it in a conference that I was giving in 2006 at the beginning. And so I have not seen it take off as much as I believe it perhaps should have. Can you tell us what are the weaknesses, as you see them, of the competency-based training? Why doesn't it just spread like fire?
Well, so I challenge the fact that it's not I'd agree with you it hasn't taken off, but it is taking off. So, for example, our Royal College has developed a policy statement that we're going to have something called competency by design by 2017. And what that implies is that every one of Canada's training programs will have many, if not most, of the essential elements of competency-based education within 4 or 5 years. So our college certainly has looked at this as a positive experiment, and indeed it's not the only experiment. There's others across the country in evolution. So I do think it's taking off. It's not easy. You're dismantling a traditional way of training, and our trainees spend a lot more time in education. 6 times fold the assessment is a big struggle to accomplish. And it takes dedication, like we had from 60 orthopedic surgeons in Toronto, and a team of champions, those 4 individuals who I showed on the slide. So I'm not sure that it has or hasn't taken off. Change is difficult, but change is what we desperately need at this juncture in time. So I think we're going to see it. And it's not just Canada, of course. The U.S. with its Milestones project is one of the underpinnings of a competency-based system, and it's getting there. And I'd say that I've seen evidence of it around the world as a brewing momentum.
I think competency assessment has come in a major way, in both ways, both with an apprenticeship scheme and with the new methods that have been developed by Richard. And that's not going to go away. I think it's without doubt the way forwards, and I was very, very impressed when you started using that for orthopedics, because it has transformed standardized training in this country.
And I might say, Dr. Wallace, that David Pitts came to Toronto to teach us how to do PBAs as we started our program. So we've inherited a lot from you.
Okay. Somebody down at microphone 1 there.
Thank you very much. Jared Parlin, I'm president of the British Orthopaedic Trainees Association. I've heard, thank you very much, for 2 excellent talks. One is a comment and one is a question. Comment is actually, I don't think either view it's a binary system. I do see there are principles in both your talks which apply to the very heart of surgical training. And actually, I don't see it as being one or the other. However, in the UK, the big problem, as certainly we see it in BOTA, is that there is a difference in how hospitals, NHS trusts, view training. Angus alluded to that earlier by saying that although we are there and we provide service to a large extent, from a hospital's point of view, we are often viewed as actually being an expensive way of providing service, and training seems to take a secondary role to the service provision. And part of that problem then leads to how we then use work-based assessments.
But Jaya, can I just respond to that? I've told you what to do. You audit the 48 hours that your trainees are doing. hour by hour, to see what the strong parts of your training are, your training week are, what the weak parts are, and then modify it?
If I was say, we know where we want to be trained. The fundamental principle will be, I certainly do not believe all consultants should be trainers. I think you need to differentiate the ones who are interested and good at training from the ones who have absolutely no interest, and that's fine. They will then go along and do service. At the moment, what you have is a bit of a mixed bag where actually the very good trainers are struggling to provide training because they're also being asked to provide service. And competency-based assessments are being done at the end or as a final bit when actually they need time to train. And hospitals have to have an incentive to actually be incentivized to look at training as actually leading to good service as well.
I think so I think you've identified some very important issues, but I'd like to take the issues up 10 or 20,000 feet and ask the question, who runs the British training system? I think to me that's the essential question, and what's the role, the governance role of hospitals in running a training system? Because I would argue right now that it's extremely different in Canada compared to the UK in terms of who's in charge. There is no question that the universities are in charge of the training system in Canada, and it's not the hospitals. And I would, having just spent a week in the UK preparing for the BJS lecture on Thursday, I can tell you that it's just not like that, and one could argue that the hospitals have no business being in charge of an educational program.
Okay, microphone number 2, there's somebody who's been waiting there too.
Good morning. I'm C. Rohrbeck, orthopedic surgeon and president of the Royal College of Physicians and Surgeons of Canada, and a friend of both of the debaters, incidentally, and I thought the guys did a hell of a good job. I was very, very pleased with that. And of course, being a Canadian and recognizing the issues we have with competency and trying to improve our residency training programs, I have to come down on the side of Richard as far as that's concerned. But the question I really wanted to pose to the audience, or to you two guys, because you're so learned and knowledgeable about this, is something you said, Richard. We should be training for jobs. And I was going to ask Angus about this. This is something that we need to do here in the UK as well. Because in our country, what happens is that people go through 5 years of orthopedic surgery. They're very well trained, I think, in terms of all the basic skill sets, the CanMed competencies, and so on. And then they get a job in some town, Kitchener, Waterloo, for example, where they said, well, you know something, we really need a hand surgeon here, or we need a hip surgeon. So off they go into another year of hand surgery because they don't feel competent enough in terms of what they got in their training. And then, perchance, they go into another year of hip surgery because they think maybe they need that as well in this particular town. So should we be training these people for the jobs that they're going to be required to do, whether they're going to Cornwall in the UK or someplace in Ontario? So I'd like the two participants to address that, please.
Principles adopted by the SAC in orthopedics are that the trainee at the end of training should be generally trained so that they can deliver a trauma service for people coming in with fractures. They should also be able to carry out our commonest operations, which are hip replacement and knee replacement. The other areas of orthopedics, hand surgery, shoulder surgery, etc., are, if you like, add-ons that are addressed at the end of training rather than during training. Yes, you get some basic hand surgery, but not hand surgery required of a specialist hand surgeon. So we are training generalists in orthopedics, but see, you have identified a very real problem, because there is a degree of super specialization which is an issue and is causing a problem in the UK. And if you go out to our non-teaching hospitals, I'm not happy that we necessarily have trained these consultants well enough for the generalist jobs that they're doing. We have trained them for it, but not well enough.
Richard, briefly.
Yeah, well, I'll talk about this a little bit tomorrow, and we absolutely need generalists, and we absolutely need specialists, and there's different training for each group. And I think if either of our country could commit to doing a better job at HHR planning, we could define what we need, and then we should train towards those jobs.
Okay. Unfortunately, we are running 10 minutes over time, so we are going to have to draw it to a close here. But before we finish, we are going to vote again on the motion for this debate. So if we could have the motion up, and if you get ready to vote, do you think that supernumerary training is better than the old apprenticeship model? 1 for yes and 2 for no. Let's start voting now.
While we're voting, could the projectionist get my presentation and go to slide 30, please? Once we've had the vote. It's not changed.
In fact, there's been pretty well no change since the start of the debate. Okay. Okay, well, I think it has been a very worthwhile and very productive debate, and I'd like to thank our 2 speakers and also to all the participants in the audience. Thank you very much.